My name is Swahn, and I'm an upper GI surgeon at the Gastrocentrum Surgery at the Karolinska University Hospital in Stockholm, Sweden. I was asked by the DDW administration to discuss our poster displayed during this year's meeting in Chicago. I'm presenting a poster together with my colleagues Urban Arnelo, Magnus Nilsson, Gunnar Persson, Mattias Lör and Lars Enoksson, entitled Rendezvous ERCP technique results in fewer cases of post-ERCP-pancreatitis compared with conventional cannulation technique, a prospective nationwide population-based cohort study in Sweden. The background to this paper dates 11 years back in time, when we at Karolinska started to perform rendezvous cannulation during routine laparoscopic cholecystectomy for the treatment of common bile duct stones. Our first years of experience was presented in 2004, where we could show that this was a feasible approach to treat common bile duct stones as a one-step standard procedure. And moreover, we noticed that we had virtually no cases of post-ERCP pancreatitis. And above all, this trend was maintained. In order to address the very pertinent question whether there is a difference between rendezvous and conventional cannulation technique in developing post-ERCP pancreatitis, we explored this question in a nationwide register, the Swedish Nationwide Quality and Assurance Registry for Gallstone Surgery and ERCP, called GALRIX. It's a unique registry where more than 85% of all Swedish hospitals performing ERCP and gallstone surgery participates, and the presented data represents about 95% of all ERCPs performed in Sweden. The protocol uses an internet platform with online data registration of the procedures. The questionnaire compiles approximately more than 100 different variable possibilities relevant to the complexity of the procedure. Data were recorded by each endoscopist at the time of the procedure, and each patient file was closed after every single registration and could not be altered by the investigator himself. Follow-up data is collected locally by each institution, usually done by a dedicated coordinator 30 days after every ERCP, through medical charts reviews or telephone interviews with the patient. For a period of 3 years, from 2007 to 2009, a total of 18,286 ERCP procedures, regardless of indication, were registered. In total, 3,821 therapeutic ERCP procedures with an intact non-sphinctertomized papilla were performed as a consequence of common bile duct stones. All these patients had a complete 30 days follow-up record. In 337 of these procedures, cannulation was done by the use of rendezvous technique, and 3,484 procedures were completed by conventional cannulation techniques. In total, the 30-day complication rate was 11.2%. Post-ERCP pancreatitis rate in the conventional cannulation cohort was 3.9%, and for those who were cannulated with rendezvous technique, only 1.5%. Accordingly, this prospective cohort study shows somewhat more than a 2.5-fold reduction in post-ERCP pancreatitis incidence for those patients who underwent rendezvous cannulation technique. A potential weakness of this study is a selection bias of age, in the sense that patients selected for rendezvous are also considered to be fit for cholecystectomy, compared for those who are selected only for ERCP with conventional cannulation, who are somewhat older. But any such selection bias would, however, not really explain the findings, but rather underestimate the observed differences, since we know from large studies that younger patients with a healthy pancreas are at larger risk of developing post-ERCP pancreatitis. In summary, Previous small-sized studies have proposed a relation between rendezvous cannulation and decreased risk of post-ERCP pancreatitis. These preliminary observations can now strongly be corroborated by these data originated from a nationwide quality register database. Moreover, since it's known that young age, long procedure time, and repeated or extended cannulation procedures enhance the risk of developing post-ERCP pancreatitis, thus rendezvous cannulation should always be the prioritized approach in these situations. Thank you for listening.